So good evening, everyone, and thank you for your attendance at tonight's Victorian Clinical Network for Abortion and Contraception Care. And as previously stated, tonight's session is being recorded and will then be uploaded onto the Search website for those who can't attend or those who wish to hear it again later. This is always a very efficiently run session, and so without further ado, we'll start. I would like to commence the evening with a welcome to country and acknowledge the Wurundjeri people of the Kulin Nation, on whose land I am this evening standing and presenting to you from, with an acknowledgement of elders past, present and emerging, and an acknowledgement that we are in multiple sites and that multiple welcome to country may in fact occur during the meeting. Please introduce yourself via the chat. So for those of you that are on chat, or as when you're talking, could you introduce yourself briefly before you start to talk? Thank you very much. Mute your microphones when you're not speaking. And if you have questions during someone's talk or when someone's speaking, just put it on the chat function and Nisha and I will keep looking at that and make sure you don't get missed out. So without further ado, I'm going to hand you over to Carolyn. For those of you who haven't got an agenda in front of you, Carolyn's going to give us a snapshot of the current landscape via the lens of 1-800-MY-OPTIONS. Then Sarah Lim, who's a GP registrar in Bendigo, is going to give us a case study presentation. Then we're going to talk briefly about the new RESIS D guidelines that have just been released. And then there's always a chance at the end for people to give an update from their region or to ask any further questions before we close at 7. So over to you now, Carolyn, for your update.
Thanks, Patty, and thanks everyone for having me. So I'm the manager of the 1-800-MY-OPTIONS service, Victoria's phone line for contraception, pregnancy options, including abortion and sexual health. So the 1-800 service is running as normal now. We do a quick pivot to all work remotely when we have our various lockdowns and then go back to the office as required. We have been having relatively regular numbers of calls per month, as is normal for the service, but something that we have been noticing since the start of the COVID pandemic is that we continue to have higher numbers of callers who are experiencing financial insecurity. So before COVID, was around 30% of our callers said that their financial insecurity was a barrier to accessing sexual and reproductive health services. During the peak of last year, it was up to about 50 or 60%, and it's stabilised for 2021 at around 40%. So I think it could be said that potentially the impacts of that pandemic are still being felt quite significantly around people's access to SRH services. We're still hitting around 11 to 15% of our callers are coming from rural areas. We have around about 30% of our callers born overseas. We've also seen a slight change in some of our figures for people who are in the second trimester and seeking abortion services. So generally that sits at around 3.5% of our callers in the second, 3.5 to 5% of our callers, and it's increased a little bit in 2021 to around 10 to 15%. So this is something that we have to juggle a little bit as we're working with the callers to find out services that can meet their needs. We've also had some slight changes in provision of second trimester abortions as well. And so that's impacting where we can provide referrals to. In addition to that, we are looking a little bit more closely at a lot of our data so that we can work better with people in the regions around demand and supporting demand and supporting service establishment. So if anybody is looking for 1-800 data to support the establishment of services or the expansion of services, or to just look at the needs in their community, please get in touch. We're really happy to talk to you. We may not be able to share data in a way that could be published, but we're definitely willing to have a chat to people, particularly in regional areas, about how we can support you to build and support and develop your services. Thank you.
Thank you, Carolyn. And once again, I'd just like to sort of acknowledge that 1-800 My Options is the de facto abortion database for Victoria. And this was one of the possible outcomes that we had hoped for, but we didn't imagine it would be as rigorous as it has been. And it's actually really sensitive, and you can postcode, etc. So I would encourage any teams that are wanting to have a look at their area and the postcodes that triage into their area to get that information. The other thing I wanted to acknowledge was your observation that the number of calls requesting second trimester service has increased in 2021, and I just wanted to echo that in terms of the service that we're providing at the Royal Women's, that has really been a definite trend right from the beginning of the second lockdown and continues to the present day. So that's also very interesting. Are there any questions for Carolyn? Either on the chat, I'm not sure that I see any on the chat, but if anyone wants to raise their hand and ask Carolyn a direct question, now's the time.
I do, Patty, if that's
Hello.
okay.
Hello, of course you can.
Thank you. Thanks. So, Carolyn, that is exactly the question I wanted to ask. You said there's been a change in services, so that means that there's a reduction in services for surgical terminations in Victoria. And can you tell us who they are? Because if we have to refer to someone, I don't want to ring somebody that's not providing that service anymore.
Yeah, so we have had the change appear on our database, on our GeoMap, so it is visible that Murray Stopes have changed their gestational limit. It's moved down to around 14 weeks, and so that's from 20 weeks that they were at previously. We do have, in terms of provision, we've got the women's, obviously, where there's another public hospital that can go at times up to 16 to 19 weeks. We've got private providers that can go to 16 and 17 weeks. So we do have the capacity to make referrals through the system. It's just about diverting them in different directions.
And just following up, just following up from that, Louise, the efforts that 1-800 have been doing to make that transparent on the geomapping is so that patients aren't interacting with a service that previously could do it, then waiting to get a call back, a week goes by, the weekend happens, or there's a long weekend, and then there's a delay till they get into the next service. So thank you very much for that coordination, Carolyn, yet again. I think we'll move on now, if that's okay, unless there are any other. Here's a question from Stephanie Chen. Hi, Carolyn. Do you talk to, refer and or record post-TOP client data?
Our service is strictly anonymous, so we don't have any way to follow up any post-service data. Even if somebody calls us again the next day looking for further services, we can't refer back to the original conversation that we had with them because we are completely anonymous.
Thank you.
Thanks, Carolyn. Sorry, I'm just slipping in and out visually, but I appreciate that feedback because we'll be launching with a lot of appreciation for 1-800 My Options support, that sort of mapping in Queensland as well. But our counselling team has seen a spike in post-op, and just noticing that spike in second trimester. We also have seen a spike in post-op counselling requests. So it was you know, that was where that question came from.
Right. Yeah. So we'll go on now to Sarah Lim's presentation. So Sarah.
Yep. Hi, my name is Sarah. I'm one of the GP registrars working at Bendigo Community Health. So I'll just share my screen. I've just got a short case that I'll try and share. Oops. Give me 1 second. Too many things open. Can you see my screen? Yeah, great.
Yes, Sarah, it's all there.
Beautiful. So it'll be a short one. So this was a case of MTOP, a lady seeking medical termination of pregnancy, and we just had some difficulties clarifying if mifepristone was safe for her. So we just brought this case up because we thought it was interesting. So there was a 46-year-old G4P3T1 who wasn't planning a pregnancy, but she was referred from Bendigo Hospital for medical termination of pregnancy for an incidental intrauterine pregnancy at 6 weeks gestation when she was doing an ultrasound as part of her kidney transplant workup. So she is a patient with end-stage kidney disease, likely secondary to polycystic kidneys, and she was on peritoneal dialysis, and she was being worked up for kidney transplant. Second, because of her kidney disease, she has hyperphosphatemia. Otherwise, she's healthy, and she's had 3 normal vaginal deliveries. She's only taking sevelamer, and that's for the end-stage renal disease. She's not on any other medications, and she doesn't have any known allergies. So because we're not sure if mifepristone was safe in this population, we know that it should be avoided in severe renal hepatic impairment. We called MS 2-step hotline, who got back to us a day later, but they said that they were not sure because mifepristone wasn't studied in this patient population. So they suggested calling Mary Stope. So we called Mary Stope, and they similarly mentioned that there's no studies showing that, no studies of mifepristone use in this population, but they suggested that 1 dose should be safe. And the last sort of resort, we rang Bendigo Hospital ONG team to get some advice. So after speaking to, I think, a few consultants, the registrar advised that a stat dose should be safe, and similarly, no strong studies of mifepristone use in end-stage kidney disease. However, just weighing the pros and cons of this lady having medical termination versus surgical termination, they deemed that she's at high risk of complications if she went through surgical termination. So they recommended trying medical termination first, and then surgical termination if the medical one fails. So she had, we consented her to have medical termination of pregnancy, and she tolerated the procedure well. She didn't have any complications, and the procedure was successful. So her repeat beta HCG dropped by more than 85%. So now she's been consented and waiting for a Mirena insertion as long-term contraception. So I suppose, as I mentioned before, so the issues were there was lack of studies regarding the safety of mifepristone in end-stage renal disease, and I think coming from a registrar perspective, and even speaking to my GP colleague, it was really difficult to get advice about the safety of medical termination of pregnancy in this population. So this patient actually had a few appointments over a week, but finally got, consensus that we should try MTOP and see how we go. So that was the case. It's just a short one. Yeah. Any questions or any ideas?
So look, I'll start with comments. Thank you very much, Sarah. It's always really good to have, a conversation starter like this. And I guess your case illustrates the point that when studies are done on safety, particularly on an intervention such as this, there isn't going to be an exhaustive randomized controlled trial in a group of patients with this condition. But there will be some pharmacological and pharmacokinetic evidence about how mifepristone is handled by the kidney. That's probably all we've got to go on. But it does illustrate the point of how tricky it can be when you have the patient in front of you trying to get a quick answer. And the ask the expert phenomena can be probably a wee bit frustrating for GPs. This is the first end-stage renal patient that I've heard of requesting an MTOP. We've had a couple who were insistent or were of a gestational age where we had to do a surgical abortion. Could I just ask you a question? When you talked to the team at Bendigo, was the concern about the surgical abortion the anaesthetic concern?
Yeah, anaesthetic concern, and also they will be doing laparoscopy, so having peritoneal dialysis. They were worried that if there are any complications with the laparoscopy DNC, it could affect her peritoneal dialysis. I think that was their concern.
So they're saying if there was a complication, they would have to do a laparoscopy.
Yeah.
Yeah. So was the thought ever raised that this patient could have a surgical evacuation under local anaesthetic? Was that ever raised, that she could have a cervical block with sedation?
I wasn't aware of their discussion, but I suppose that would be an option. Yeah.
Yeah. So the two cases that we've talked about, that's how we did them, under local anaesthetic. And so you can get a really good anaesthetic blockade and sedation via intravenous sedation without having a full general anaesthetic. So there's a thought, so there's always 2 or 3 possible options, but it's useful to know that she had an okay experience. Did she give you any feedback about her experience?
I think she was just initially a bit upset because we had to say, I'm sorry, we have to call a few more people to get back to you. And she was very anxious because it wasn't a planned pregnancy at all. So she was a bit upset about sort of having to wait for a decision or a plan. But I think with repeated sort of explanation, saying that, we just want to make sure this medication is safe for you and it's not well studied in someone like yourself or end-stage kidney disease. She was very understanding of that, and we kept her in the loop. So I think she was very grateful. And the fact that MTOP worked for her, I think that was definitely a perk.
How many weeks was she when she had the MTOP? Was she 6 weeks or 7 weeks by the time she actually had it?
7 weeks.
Yeah, 7 weeks. So you still turned that around really quite quickly. Before we open it up to anyone else, I'm sorry, I'm monopolizing you with questions, but I'm really interested in your experience of seeking help. And what would you recommend next time to somebody who was seeking help? Was ringing Marie Stopes helpful? Was ringing the local hospital helpful? Would you prefer some kind of centralized tertiary consultation line to contact? What are your thoughts on that?
Yeah, I think a centralized one would be great, but I found that calling Bendigo ONG was probably the fastest and most efficient way. I found that calling MS2 Step, like they firstly didn't answer the call, but then took about 24 hours to call back. So that was a bit of a delay. Mary Stoke was quite quick with their response, so that was good too.
And their response was that they hadn't had experience.
They haven't had experience, but they suggested that 1 dose wouldn't hurt. Yeah. But I thought with this case, it's probably better. That was what my thoughts were. It's probably better to get a few different opinion and then, present it to the patient and have a shared decision making. So that's what I did.
Mm. So I was just wondering if anyone else who's done medical abortion services would like to comment on this case, or on if you want to segue off to another case where you had difficulty or had an experience seeking tertiary consult. Does anybody want to say anything? I was wondering, Kathy McNamee from Family Planning, have you had any similar cases?
Sorry, Patty, just trying to unmute myself. No, we haven't, and I just think it's amazing that you sort of persisted and stuck with it and just didn't throw your hands up. But we have had good advice from you and Murray Stokes. People have been very responsive, but it is, you know, it is sometimes difficult to get a quick turnaround with an answer.
Have you? And you've not had someone with renal disease?
No, we haven't. No, I mean, which is sort of surprising. Yeah.
Well, I think the answer is that fertility is enormously compromised in end-stage renal disease, and people who are in end-stage renal disease are feeling really unwell.
Oh, that makes sense. Yeah.
Yeah, and so there probably isn't quite as high an incidence as we might otherwise see. Would you like to share with us any unusual cases then that you've had that you had to?
Yeah, I'm just trying to think, Patty, while we were talking about the different ones we've had, and I can't. Most of the ones that we've had have sort of been fairly obvious that they can't have a medical. I'm sure they'll start springing up in my mind, like as we go on.
Shall I continue to confabulate?
Yeah.
Yeah, so I'll confabulate a few that I had from the regions, you know. So these are cases that actually came from people such as myself, Sarah, or people up in Ararat. So we had a patient from Ararat that I remember who was 6 weeks pregnant, had a previous MTOP. She'd had a good experience on that, but in the meantime, her asthma had flared up and she was now on a reducing dose of prednisolone. So she actually was not a good case for mifepristone, because high-dose steroids can interfere with the receptors. So the mifepristone would have been ineffective. The same with someone who was on steroids for any reason. So you occasionally get an end-stage renal disease on steroids, but I don't think she was, from what you said. But there are certainly unusual cases like that. High-dose steroid inhalers, we've had to make a bit of a call a couple of times, and I wonder if anyone has had an experience of that with a woman who's had an intercurrent infection and was increasing her inhalers. There's no evidence on what becomes a high dose, too high a dose, but what we did decide in the end after talking to a group of physicians was that if it was oral medication, even if it was on a reduced dose or a reducing dose, that would be a contraindication. But if it was inhaled steroid, it wouldn't be. Just wondering if anyone else has had that problem to think about.
We've had a few like that, Patty, and I suppose the sort of thing is that, like, if they, you know, they might be a little bit brittle and have steroids occasionally, but as long as they've sort of, you know, seem to understand, have a good asthma plan and not too far away from emergency services, we've gone ahead.
So Sarah, I'm just looking to see if anyone else has got any questions for you or anything to add. I'm just reading down. Has anyone? There's a lot of comments, but they're mainly introductions. Did anyone else want to add anything? Sarah, was there any accumulated wisdom within the group where you're practicing? Did you ask any of the other doctors who prescribe up in Bendigo?
In regards to this case?
Yeah.
Actually, you might know Dr. Punima, so she's my supervisor.
Mm-hmm.
And I ran this case past her, and that's why she thought it's a very interesting case. And she's the one who prescribed the medication. But yeah, so she said to present it. But she thought it was an interesting case. Similarly, I think we just got advice she was the one who said to get different advice as well. So I think it was a good learning case for us.
Mm-hmm.
Yeah.
Any other comments? Or anybody else want to share an interesting case they've had recently?
Actually, Patty, the other one that we've had a couple of people who've got sort of lowish hemoglobin and low iron. One of our doctors organised an iron transfusion, and I keep for someone who was sort of really borderline, I keep needing to look up how quickly you'd expect it to sort of come up and make it okay to have a medical termination.
So we've had that situation where we've been given iron transfusions for somebody who we're doing a surgical termination on, and the hematologists have said give it a couple of days.
Yep.
Only. Yeah. We do give transfusions immediately pre-op as well, because the assumption is you don't want to delay their procedure, and the iron will continue to work right through. So you could also use that rationale. So it wouldn't, because you don't want to be delaying someone a week. Like this patient, they're going to get more and more anxious, and you may delay them beyond the window for doing the early medical abortion.
Yeah. The other one that we come up against that people are sometimes reluctant is with insulin requiring diabetes. I mean, I usually feel okay about it as long as they're sort of aware of their hypos and stuff. But just wondered if you had any comments about that.
Well, you don't have to fast.
Yeah.
So I think it's fine. You don't have to fast, but I guess we all know that we need to talk to our patients about not doing their early medical abortion on their own in the middle of the night so as not to inconvenience anyone, which a lot of women have, we've all had experience of women thinking that they'll get everybody to bed and then just quickly take their misoprostol. So doing it during the daytime and when there's people around and when they're eating regularly and taking their usual meds. The other interesting complication that I've had from several of this family, this network, is patients who've had an intercurrent diagnosis of cancer. So they may have just been about to start on chemotherapy, or they're on chemotherapy and their platelets are low. And so those have been two or three cases in the last year. And prior to chemotherapy, there would be no reason for them to not do it. And the quicker the better. But the two that I remember the most are those that were a little bit like your patient, Sarah, an incidental PET scan or another examination has revealed abnormal blood flow in the pelvic region, and this has turned out to be a pregnancy. And in those cases, we have managed them with platelet infusions if they've been on low platelets. So that is one that I would always escalate, and I would always escalate it probably via us and the VCNACC, and we would make a decision with them. But that has occurred more often in the last year than any other concurrent medical condition. Anyone else? So there was a question that came through. I do apologize, I can't sort of read everything at the same time. It was from Liz in Shepparton. What was your question, Liz?
Oh, hi there.
Hello, Liz. How are you?
Hello, I'm very well, thank you. How are you?
Good.
I was really just wondering about termination in different language, information about termination in different languages. And Nisha replied to me privately. I've tried the Better Health website. I think it's Better Health. I've tried the translating services. We've just got a lot of patients around this area who are fruit pickers, fruit packers, and they don't, they do not speak very good English, nor do I, but it is quite difficult. And the other thing that is very interesting, what Caroline was saying, was that a lot of my patients are having huge financial difficulties, which is an ongoing problem with the practice, because they want me to charge, and yeah, sometimes that's difficult.
Yeah. Did you find any resources?
Sorry?
Did you find any resources?
It was okay. It gave me some basic information to try and explain to the patients with Better Health. But a lot of the patients are islanders, and that these languages don't seem to be there. Not that I can find. And some of the personal translating service is okay, but I just wondered if anyone had any good advice about resources that were available for non-English speakers.
So let's put that out to the group. What I would say is that the women's we're really on the back foot. We are the abortion information translation is way below all the LARC information translation services, and so we're waiting to come up in the queue for our translation. But I agree with you, Pacifica translations are not coming up as numerically enough for us our hospital to do those translations. However, on a one-on-one basis, because what's really useful is to have a piece of paper that the woman can refer to know when is the right time to seek extra help if the bleeding is too heavy, or if she thinks she's got an infection. And those things being translated on a one-off basis would be really useful. And that's something perhaps if you, I will get Kath Hannum when she comes back from leave to contact you, Liz, about what might be the most common language translations you need up there. And we could possibly do one-on-one through our translation service while we're waiting for some of the others. And then at least you would have that. What about anyone else? What about these days at family planning, Kathy? Are there any translated information sheets on abortion?
No, we don't have any, Patty, no.
Yeah. You do have that interactive translation on your website, but that's for LARCs, isn't it?
Yeah.
Yeah.
Yeah, it is, yeah. I mean, there's a small video on abortion that covers abortion, but it doesn't, like nothing about the details of it at all. I mean, just mentions it.
And that's available in lots of different languages, but it just mentions that it's a possibility. Is that right? Yeah.
Definitely an area in Queensland that we are looking at, Patty and Kathy, and I've had some conversations with Kathy about some of the easy English resources, because we're also aware that some people from non-English speaking backgrounds may have verbal language skills, but not necessarily written language skills. Like they may not have had kind of education, maybe come from perhaps a refugee setting where they've learned the language to speak, but they don't necessarily read. So we've got two current projects. One is working with women with intellectual disability, and the other is working on a language inclusive project, and we think there might be some synergy with some easy English redevelopment of resources, and I have spoken briefly to Kathy about that, and looking to get some additional funding to try and look at the spaces of thinking and talking about pregnancy decision making, thinking and talking about contraception, and thinking and talking about abortion as an adjunct to pregnancy decision making. So there's definitely a gap there. And I guess the other thing that I would say is, and probably Carolyn would have some words to add, is that in terms of you know, getting translating, interpreting services to speak, that we need to be really mindful that it's best to ask for an interpreter who's comfortable to talk about abortion, an interpreter that's not in the same state as the woman that you're working with, because it's possible that they might be connected with community, and preferably a female, but that's not necessarily possible sometimes. But that's certainly been, you know, that's like a rule of thumb for us, is that we try and find someone who...
Thank you. I think it's I think it's really got to be a challenge that we take up here with our Clinical Champions project, that we look at trying to get some dedicated funds to develop these translated pages. You know, it's taken us so long to get the ones on LARC, and they're always just put on the back burner. So I'm writing it down, Elizabeth, and circling it, and I really think that we've got to do something about this. And so hopefully by the time we have our next network, I'll have some something useful to share about that. So thank you for bringing that up. The next item on the agenda I'll move to, unless there's any pressing questions from anyone. I'm just trying to see if there's any new messages. So Alison has said, we see many refugees at our clinic, very few resources, Swahili, Nepali, and Kindanwanda. And Heather suggested that some of our New Zealand colleagues might have some of the Pacifica information. What a brilliant suggestion. And I'm having a meeting with some of the New Zealanders soon. So again, I will mention that, because they may have some of the Pacifica Island languages. Thank you. This is one of the many useful things about this network, is that there's always someone with an idea to share. So look, I thought I would move on now, if that's okay, briefly to talk about the new guidelines. And this is about rhesus D immunoglobulin in early pregnancy. And I'm just showing you the front page of the guidelines, which have just come out. And something we could do for everybody is we could send a link to the guidelines to everybody who's been a participant tonight, because I've printed this out because I'm going to use it a lot as a teaching tool, but it's 93 pages long, and there are about 2 pages that pertain to early medical abortion. So if we send it to you as a link, you can have it on your favorites and have a look up on it. The comments we wanted to make about it are to remind people that within the context of the pandemic, the Royal Australian and New Zealand College of ONG very quickly responded to a request from some of us clinicians to make a deliberation about the need for anti-D in early medical abortion. Most of you who are involved in early medical abortion know only too well that this is yet another barrier for the rhesus negative woman, another episode of care or some other visit she has to make to get her anti-D, and sometimes queuing up as a category non-urgent patient in an emergency department on a busy weekend to try and get her anti-D, and finding this a very difficult experience. Also, GP practices and other community health centres who wouldn't normally stock anti-D, having to think about, should we get a stock of anti-D, how often are we going to need it, etc. And so we followed the clinicians when we brought it up to the RANSCOG board for consideration. We were following some of the guidelines that had come out of Britain and Europe, and the RCOG guideline had changed to recommend that it was no longer required for those having early medical abortion. Now, in lots of hospitals protocols, there was a huge amount of variation in what we individual hospitals were recommending and what individual practitioners had been taught, in fact. So the good news about the guideline, the previous guideline was published in 2003. So that tells you how long ago and how needed this was. So this guideline was developed over the last 3 years, and the latest evidence in it, and this is important for you to know because some of you will have read further research which might contradict some of the guidelines. The latest evidence that was admissible for this guideline was on July the 19th, 2018. So that's when they closed their research for looking at their guidelines, and they developed guidelines based on a committee of experts, and where there wasn't particularly good evidence, they had a rigorous debate on what evidence was available and came up with recommendations. And so with regard to early pregnancy, the news for us in the early medical abortion world is good. They have recommended that termination of pregnancy where it's a medical under 10 weeks does not require the prescription of anti-D. Now, how they have phrased that is they asked a whole series of questions. They asked 4 really important questions off the literature. And the question they asked with regard to anti-D usage in the first trimester was, is there evidence that supplying anti-D immunization prevents immunization occurring in the next pregnancy or in 6 months' time? So they were looking to see if there was any evidence that it made any difference. And the studies that they found were few, far between, and poorly powered, and not directly comparable is the way I would describe the evidence, having read it. But the recommendation is that we don't have to give anti-D in the first instance in medical abortion, nor do we have to give it if there are retained products post early medical abortion and the woman requires a curette. But if it's a surgical abortion, that they do require anti-D. So if it was a failed medical abortion and then they had to have a curette with an ongoing heartbeat, the recommendation is that they would have anti-D given. But the caveat over all of this is in the first trimester, it is very low grade evidence, but expert recommendations.
Patty, would you consider it in any circumstance like a multiple pregnancy getting towards the 9-week mark?
Well, again, there's no evidence. Yeah, and there's no evidence when you do a curette for a miscarriage in that same circumstance, that giving the anti-D confers a huge benefit. So I would just stick with the gestational age guideline, not the number of pregnancies. Yeah, because it's the event itself. It's not supposed to be sensitizing. Yeah.
Yep, that's great.
Patty, what about threatened miscarriage?
Threatened miscarriage, there's no evidence. But, you know, I would always just quote my professor of obstetrics and gynecology. Just because there's no evidence, it doesn't mean that what you're doing isn't the correct thing. You know, no one asked that question about threatened miscarriage, but they haven't got a sufficient sufficiently powered study to say that giving one dose of anti-D in a threatened miscarriage situation confirms a decreased risk of isoimmunization. And it's because there might be a study, the study I looked at in depth was 241 people. There was 1 in the intervention arm and 2 in the placebo arm. So it's not powered enough to show that there is an absolute indication. But there is expert advice that if they're bleeding, Sarah, goes on and is prolonged, that anti-D could be prescribed. And if somebody continued to bleed, say they had a subchorionic hemorrhage in a miscarriage, and they continued to bleed, that you would re-dose them under 12 weeks after 6 weeks. So if they presented at 6 weeks and they were still bleeding 6 weeks later, you would re-dose them. So that would be a very unusual presentation if they were continuing to bleed like that.
Great, thank you.
That's okay. I hope it's clear that the whole thing comes with a caveat that this is a guideline and it can be personalized for the individual patient or practitioner. And the corollary of that is that they take no responsibility for any adverse outcomes as a result. But it is the most comprehensive anti-D guideline I have seen. And I'd advise you to sort of look through it, and then there is a chart of first trimester and who should not get anti-D. So that's probably the easiest way to read it. Any comments on it? Any people who've had experience with it thus far, or any problems with patients having being told that they needed to have anti-D? We've had several patients that we, during the pandemic, gave early medical abortion to, who were rhesus negative, and we gave them an information sheet that they didn't require anti-D. They presented at a different hospital with ongoing bleeding and were told, shock horrors, didn't they give you anti-D? So we have tried to message all of those emergency departments, and so we're really thankful that we've now got this to refer to. But have any others had any experience like that? Have most of you changed to not giving anti-D?
Yeah.
Yeah, anyone, any team that hasn't yet? I think it's been fairly well accepted, hasn't it? Because it's, for once we're taking away another thing that somebody has to do.
Yeah.
And if any of you've got any ongoing questions from that, you can message us directly, Kath or I, or via the SERSH website. And finally, just before we end up, because I see it's 6:52, do any of the teams involved tonight want to share anything that's happening or any updates on their current service system, anything they want the rest of the network to hear about? Or any other questions?
So Patty, I've got a question. It's Louise.
Hello.
Again. I had a lady who was rhesus negative and had in a previous termination of had anti-D, and so she was absolutely determined that she wanted it.
Mm-hmm. And so that's an example of page 1. You can you can modify the guideline to suit the patient in front of you. Yeah? And it's highly unlikely that an adverse event would occur for that woman as a result of you administering the anti-D.
Mm-hmm. Yeah, thank you.
Yeah. I thought you were going to mention those patients who were already immunized. So if you know, when you do the first blood group and they're anti-D positive, but they are previously immunized, they generally would not require a further dose of anti-D. If they're having an ongoing pregnancy, the recommendations are that you coordinate their care with the local secondary antenatal care provider. But if it's in the condition of a termination of pregnancy, they wouldn't require anti-D. And in fact, the blood bank won't administer it if there are antibodies. So that was a really good question, and I'm sure that that would happen quite often, that people will say, but they gave it to me last time and made such a big deal of it, you know. Any others? Oh, Trish Ebert is saying, have we been prescribing anti-D as a routine during first trimester up to now? Do you want to just explain what your question is, Trish?
Well, I thought, can you hear me?
Yes, beautifully, and we can see your lovely glasses and everything.
Well, I thought we were, I guess I haven't had any experience during first trimester. We always obviously give it later, but I wasn't aware that we weren't giving it during first trimester. I thought we were just doing...
Are we talking about early medical abortion?
Anything, miscarriage in first trimester, anything. If a woman was negative, I just assumed, because of my limited experience in that part, I'm more in the postnatal.
Yeah, so it had changed, and different hospitals had slightly different guidelines because the evidence is really quite weak about it. But with early medical abortion, certainly during the pandemic, we used it as an opportunity to stop using anti-D for early medical abortion, because there's quite a lot of experience from Europe where they actually haven't been prescribing anti-D for early medical abortion for a long time, that it's not an immunizing event. So we use the pandemic as a moment where people were thinking about how do we decrease patient traffic, patient exposure to hospitals, etc. So that was where that came from. But with surgical abortion in the first trimester, we have been giving it. And surgical management of miscarriage, we have been giving it. But there was a variation from hospital to hospital about miscarriage. And I didn't go into that with this guideline. It's quite confusing about miscarriage. It's quite confusing. But about early medical abortion up to 10 weeks, it is quite clear.
Sorry, Patty, just to clarify, so with miscarriage, threatened miscarriage, we don't need to give anti-D, but the rest of them we would. Is that correct?
The rest of like if it was an incomplete or complete. That's what this is saying. Yeah, that's what this is saying. But however, and I'm very aware that this is a medical abortion forum rather than a miscarriage forum, but however, there are so many women who have an early miscarriage at home without intervention, and they're not going to be pulled in for anti-D.
Yeah, so exactly right. So I saw one who had essentially told by her GP that there's no fetal heart rate on ultrasound, and she saw me a week later after, bleeding and passing lots of clots just for a review. So I did a beta HCG and that was undetectable. So presumably she's had a miscarriage a week before she saw me. I didn't blood group and antibodies, and she was A negative. So I thought, oh, it's been 7 days. I know there's very weak evidence of giving anti-D after 72 hours, but I wasn't entirely sure. So I thought I brought that up.
So I think my reading of this is that they are saying that yes, it really decreases after 72 hours, but if you have the opportunity to administer anti-D, that you should consider it. However, do you know how many weeks she was when she started to miscarry?
No, not exactly.
It was pretty early.
Yeah, it could be quite early, around 5 to 6 weeks, but yeah, she wasn't entirely sure about her dates.
This would be an example of one I would say that you could tailor make for the patient in front of you, that is extremely unlikely that this was a sensitizing event. the earlier the event, the less likely.
Yeah. Okay. Thanks.
Any other comments from anyone? Steph has shared a link for everyone. Was the last thing. So if you have a look at that, core issues and statements from Children by Choice. Thank you very much, Steph, and a big shout out to Children by Choice for their fantastic website, which we all use a great deal. And it's 7 o'clock, and as usual, we've wrapped it just on time. So the date of our next meeting has gone out of my head. Johanna, have you got that date in front of you?
I don't, but
I can quickly look up my diary. I can
Yeah.
quickly look up my diary just to remind
I
everyone.
think it's the 24th of August, Patty.
It is. It's the 24th of August. Yeah.
Yeah.
So that's our next one, Tuesday night. Okay. But we'll be in touch before then. And those of you who I said that we would contact offline, like Elizabeth, with regard to translations, we will do so. Bye for now,
Thank you.
everyone. Bye.